Hi everyone, it's Rajiv Ramchand. I dressed up. It's your graduation from Basic Epidemiology 101, and I just wanted to celebrate it with you. This is our last session of this scheduled 9-part series, trying to teach you some basic epidemiology concepts so that you can consume the news and keep abreast of the science as it emerges with respect to COVID-19. Today's session is on case control studies, so let's get right to it. Right. So last session, we discussed cohort studies on this left-hand side, where we could estimate among those exposed who develops the disease. Sometimes we don't have that luxury to figure out, find a population of people without the disease and follow them over time and see who gets the disease and who doesn't. And in which case control studies are an attractive alternative. And in these studies, what we're going to talk about today, we ask among those with the disease who was exposed. So again, for cohort studies, we're starting with people without the disease, looking at the exposure, and then figuring out who gets disease. Here, we're starting with people with the disease and then looking backwards to understand whether or not they were exposed or not. The way we go about this is pretty straightforward. Again, 3 steps, but it sounds a lot easier than it is. We first carefully select cases. So remember when we were talking about outbreak investigations, one of the steps was having a case definition. We want to make sure that case definition, that we're grouping cases together who all had a very similar experience. Whatever the disease outcome we're interested in, we want to make sure all the cases are defined in that way. We want to be even more careful in selecting controls. We want the control group to look as similar as possible to the cases. So basically, you want the groups to look as similar as possible. And the only thing that differs between them, at least upon enrollment, is disease status. So they look the same with respect to age, their gender composition, their racial breakdown, their occupation, for example. We just want to make sure that our control group is as similar to our cases as possible. And then we collect the same information on both groups. So we want their demographic information, we want some information about their health, and then of course, we want their hypothesized exposures. And with this information, then we can then fill out our 2x2 table. Now remember last time, and from session 7, I stated that risk is the probability of an event during a specified time. So can we estimate risk in a case control study? You might think we can, because we can fill out this 2x2 contingency table. But because we're talking about the probability of an event occurring during a specified time, and we already have our disease outcomes, we can't, in fact, estimate risk. So what do we do then? How can we actually look at these exposures? And we really have to get into a little bit of statistics and math and discuss the difference between probabilities and odds. So the probability is the proportion of times you expect an event after repeated trials. So in an example that I will share later, we'll figure out that 54 out of 191 patients admitted to a Wuhan hospital with COVID-19 had died. So the probability of death was 54 over 191, which is 0.28. So that's a probability. Odds is a concept that is very unfamiliar to me, but for those people who like to bet or gamble or who follow sports more frequently, you know a lot about odds. And odds are related to the probability. The odds are defined as the probability of event occurring relative to the probability of it not occurring. So in the same Wuhan example, the odds of death is 0.28, the probability of the event occurring, over 1 minus the probability of the event occurring, which is the probability of the event not occurring, which is 0.39. And then I just did some very simple math to make that 0.39 a little bit more understandable from an odds perspective. And what you can say is that the odds are 1 death to every 2.5 lives. I've said here lives saved just to be a little bit more optimistic, but we actually don't know if these lives were saved, and if we follow them over time, maybe some of them will die as well. But let's be optimistic for now and just say that the odds of death are 1 for every 2.5 lives. So when we have this contingency table and we have a case control study, we can actually estimate the odds of exposure among those with and without the disease. So the cases are those with the disease and the controls are those without. And so your odds of exposure among those with the disease are just A, your exposure over your unexposure, the proportion that are unexposed, and similar with controls. The odds are just B over D. So how does that help us? Well, in the same way that we looked at the relative risk, which is an odds ratio over a ratio, we can create something similar that's called an odds ratio. And so there we look at the odds of exposure among cases, this A over C, divided by the odds of exposure among controls, which is this B over D. And this is just some fancy math that you just do the cross multiply, so they're all the same, and you can come up with a fairly accurate odds ratio. And what that buys us is that there's some math, and I'm not going to show it to you here, but there's some proof that when you have a disease that's not very common in the population, your odds ratio can approximate your risk ratio. So even though we're not following people over time, we can construct this ratio estimate that is an approximation of risk. So let me show you an example. This is from one of my classmates at Hopkins who graduated the same year I did. And what she and her team looked at was the risk of, or the odds of having an oral HPV infection among those with oropharyngeal cancer versus those without. And so we have the odds of having oral HPV among those with cancer. This is that 32 over 68, divided by the odds of having an oral HPV infection relative among the control group, which is 8 over 192. And so we just work this all out, and their estimate is an odds ratio of 11.3. And we can say those with oropharyngeal cancer had 11.3 times the odds of having had an oral HPV infection. That's a very strong odds ratio, a very strong relationship, and something that was published in a very well-cited journal, the New England Journal of Medicine, and a really important finding with respect to cancer prevention in the United States. We've seen a case control approach being applied to at least one study with respect to COVID-19. Again, this came out of Wuhan, China, and it was the one that I referenced earlier. So we have a group that were admitted, we were hospitalized with COVID-19, 28% of whom passed away when the study ended, and 72% had not. And so they took a case control approach to look at, well, what distinguished those who did not survive, which are cases, versus those who survived, which are pseudo controls, if you will. And so what we see here was that the age difference, the median age, those who didn't survive were a little bit older. They had higher, what's called a median SOFA score, and that is a composite or aggregate measure of organ dysfunction. And so it's generally measured when you are admitted to a hospital and then every 24 hours thereafter. So higher numbers says more organ dysfunction, and they were higher among those who died. And then this D dimer greater than 1, that's a blood marker that's indicating that you have had a blood clot. It doesn't tell you where the blood clot is. It just says that somewhere in your body there was likely the presence of a blood clot. And we see again among those who died, 81% had this D dimer of greater than 1 relative to 24% of the control group, or those who didn't die. And we didn't have that information for a bunch. That's why you see it's 24% out of 118, a different denominator. There was also some really interesting descriptive epidemiologic findings from Wuhan. I won't get into it now for the sake of time. And this paper was again from the end of March. So we've talked about case control and cohort studies, and the benefit of them, and I said this last session, is that we can establish temporality. We can have some certainty that the exposure came before disease outcome. More so in cohort studies and case control studies, but if properly conducted, we can do them well. But I do want to say that sometimes we have these cross-sectional studies where we don't have strong temporal relationships, and I don't want to discredit them because they provide some really useful information. Here's an example of a cross-sectional study, also from Wuhan. This looked at, or from China, this looked at 1,257 healthcare workers who were working in hospitals that either had fever clinics or wards for COVID-19 patients. And they examined mental health outcomes, just a point-in-time estimate, among those healthcare workers. And what you'll see is that nurses had higher scores with respect to depression, anxiety, insomnia, and distress relative to doctors. And those who worked at the epicenter of the epidemic in Wuhan had higher scores than those who worked in the Hubei province, which is where Wuhan is, but who didn't work in Wuhan itself, saying that, you know, the prevalence of mental health problems was much greater among those who were at the epicenter and among nurses relative to doctors and those who weren't at the epicenter. So this is just an example that we don't always need to have this temporality. Information like this can be really useful, especially if we want to promote kind of mental health or intervene and help those people who are most at risk or who suffered most greatly from some of these exposures that we're interested in. That's the end of this session and the end of the course. And I just really wanted to highlight my thanks to my really close friends, Nina, Alyssa, and David, all of whom really helped me construct these series and were there to talk through some of these issues that I had just to make sure I was completely clear on them. My colleagues at work who really encouraged me to do this series, and of course my family who got a preview. And to be honest, I edited some of them because some of the lectures that I gave to my family left some to be desired. So you guys got the refined version. So they were my guinea pigs. Again, thank you so much. Everyone, please stay safe, stay healthy, and stay informed. Please contact me if you have any questions or if there's any way I can help in my own capacity. You've graduated from Epi 101, put on your bow tie, and stay safe. Thanks so much.